I would like to present video surgical technique about minimally invasive dynamic hip screw fixation in stable intertrochanteric fracture. The dynamic hip screw is one of the standard instruments for intertrochanteric fracture treatment. The standard approach to proximal femur needs open and split muscle to locate the entry point of hip screw. The minimally invasive dynamic hip screw was introduced in 2004. Dr. Alobe et al. Demonstrate the safe zone where it would be possible to ream and introduce a lag screw and plate without necessarily visually identifying a major branch of the femoral artery. The minimally invasive dynamic hip screw fixation can decrease in the operating time, length of hospital stay, and blood loss compared to the conventional approach. The surgical technique is not complicated and uses the only standard set of dynamic hip screw. No significant difference between the two groups with regard to post-operative complications and implant position. There is meta-analysis compare the clinical outcome between minimally invasive dynamic hip screw and standard approach. They found that minimally invasive dynamic hip screw fixation can perform with small skin window 2 to 5 cm. And forest plot shows clinical outcome better in minimally invasive dynamic hip screw fixation group. This is an example case. 85-year-old female with stable intertrochanteric fracture of the left femur. We plan to fix this fracture with dynamic hip screw with 2-hole side plate. This is our fixation plan. After adequate analgesia, the patient was set in supine position on fracture table. The fracture was reduced and alignment was checked with fluoroscope. 2-hole side plate was placed over the proximal thigh, then used fluoroscope demonstrate planed position superimposed on proximal femur. And skin was marked in the same area of the screw hole, 3 to 5 cm in lengths. This picture is showing skin marking. The incision is done. The iliotibial band and muscle are split in one incision with the scalpel. The 135 degrees guide plate is then placed on the skin over the anterior part of the hip. A guide wire is introduced under this guide under fluoroscopic control until the guide wire overlaps the appropriate placement position in the femoral head. The correct angle and version of wire position are checked with fluoroscope as it is in the conventional technique. Hip screw length is measured with a depth gauge. Reaming was carried out through this incision. The standard hour screw and side plates are introduced through the small incision under fluoroscopic guidance. The guide wire can be removed and the plate slipped under the soft tissue until it is near the site of fixation. The side plate screws are placed in the usual manner by retracting the skin and soft tissue using a right-angle retractor. The side plate is fixed with 2 cortical screws. The skin is closed without drain application. This is the video demonstrate guide wire placement. This is the video show the reaming step through the skin window. After we inserted hip screw, the screw position was checked under fluoroscope. The side plate was slipped in the skin window by retracting the skin and soft tissue using a right-angle retractor. Side plate was fixed and the skin was closed by layer. There were some tips that can use in minimally invasive dynamic hip screw fixation, such as use a short barrel side plate, percutaneous insert guide wire before skin incision, select long hip screw that easily palpates screw shaft during side plate insertion, side plate insert with the backward position before flip inside, and using guide wire assisted side plate insert to hip screw. Thank you for your attention.